Okay. 3, 2, 1. Hey, what's going on, guys? Jerem Dasher here with Dental Intelligence, joined by a good friend and colleague of mine, Katrina Sanders. And some of you may know her as the wine genist. Some of you may have listened to her speak. She speaks all the time across the nation. Very passionate about people and about dentistry, but specifically about hygiene work and your responsibility as a hygienist. And so I'm really excited to hear the content she has prepared for you today. I know that this is her wheelhouse. This is something that she's extremely passionate about. You're going to feel it come through that screen right at you. So buckle up and prepare as Katrina takes us on this journey. It's yours.
Oh, thank you so much, Jerem. I really appreciate that intro. Thank you. I'm so excited to be here. And again, thank you so much to the wonderful people of Dental Intel for putting all of this programmatic content together. Part of my mission is to, of course, create any opportunity I can to elevate my profession and support my colleagues in excellence. So let's just get started. Let's dive right in, because as you know, this is my favorite topic. I could talk about this all day. You know, they always say, like, what is the one thing you could talk about for like an hour and, you know, just keep going? This is it. This and wine. So let's talk about diagnosing needed treatment. And I want to begin by talking about one of the challenges that we have when we don't diagnose the needed treatment. And that is this concept around the failure to diagnose. When we don't diagnose the right treatment, not only do we run into issues where our practices are not optimized enough, or we're not bringing in the income, we're not bringing in the metrics that we should, but also our patients are suffering, and we elevate our risk for ethical and legal issues. Failure to diagnose across the United States is the number one reason why doctors and hygienists are brought before their state board of dental examiners. And so, without getting too grim and serious about this, the reality is it is our professional responsibility to diagnose the needed treatment that we're seeing. So let's talk about what these strategies are going to mean. And that means looking at, number one, defining what is your baseline clinical state of health within your practice. And this is our perio edition. This is your hygiene department. What is a clinical state of health? What does that look like? We need to, of course, assess or create these assessment standards, as well as integrating diagnostic guidelines. And finally, discussing these treatment needs specifically with our patient. So let's dive right in, beginning with defining a baseline clinical state of health. What do I mean by that? What I mean is, from a health history standpoint, what does a patient who is 100% health, what does that patient look like? I think most of us would probably picture that patient doesn't have any medical conditions. They have no drug allergies. They're not on any medications. They have controlled vitals, right? A patient who is maybe not at 100% health, but at 50% health, we may describe that patient as maybe a diabetic patient who's struggling to control their diabetes, or a hypertensive patient who's struggling to control their hypertension. How can we, in our clinical position, create opportunities to move the needle, move that patient from a 50% state of health to a 100% state of health? Because I think we can all agree our number one goal is to take those patients who are diseased, they seek our care as dental professionals, and we move them from whatever their state of disease is to 100% health. And again, that also requires us to look at our patients' vital signs. Now, in clinical practice, that's not just blood pressure and pulse, but now pulse ox, and also looking at possibly utilizing hemoglobin A1C and blood glucose readings. For our diabetic patients, this is CD4 counts. For our HIV positive patients, this is a DAS28 score. For our rheumatoid arthritis patients, these are bone density scores for our patients that have osteoporosis or osteopenia. So our ability to evaluate these things helps us to better understand, is this patient 100% health? Looking at our radiographs, what is your perfect beacon of health from a radiographic standpoint? I think most of us would agree that we would want to see healthy, stable bone levels, no bone loss in the furcation, no vertical defects. We want to continue to see stability of that bone. From a periodontal evaluation standpoint, what does that baseline of clinical health look like? Generalized 1 to 3 millimeter probing depths, less than 10% of the mouth bleeding. Does that patient have recession? If that patient has recession, is that patient considered a clinical state of health? Or does that patient maybe need some additional treatment modalities to move that needle to a better state of health? Does our patient have exposed furcation involvements or a less than ideal or optimal probing depths that can make it difficult for them to maintain their periodontium? Of course, what is the presence of decay? And is that patient a patient who maybe doesn't have decay but has elevated decay risk? Looking, of course, at airway or sleep disorders, we understand that as dental clinicians, we are physicians of the head and neck. We spend upwards of 60 minutes staring down the airway of our patients. So part of our responsibility as well is now to be screening for airway obstructive disorders. And of course, finally, looking at the opportunities to integrate the knowledge we have around tethered oral tissues, looking at what these muscle pulls, these frontal pulls or tissue tags, ankyloglossia, for example, can mean when it comes to contributing to our patients' idiosyncratic challenges in the oral cavity. So we do need to establish this baseline of clinical health, understanding what does a 100% perfectly healthy patient look like? Because if we don't know what that looks like in our practice, how can we move patients to that? And that's step one. In order to do that, I think it's important for us to take a look at what we understand about the national prevalence of disease across our patient population. Now, this research study was done and it unpacks the percentage of patients that don't have any attachment loss. And we wanted to understand for those individuals who don't have attachment loss, how many people between the ages of 18 and 90 have some form of gingivitis. And what we found was that upwards of 94% of our population have some form of gingival inflammation. And within that patient population, about 55.7% of those people have a gingival index over 1, indicating that they have moderate to severe gingivitis. We've also seen the research studies that unpack the national prevalence of periodontitis, noting nearly 1 in 2 adults across the United States between the ages of 30 and 79 have some form of periodontitis. So I wanted to take a look at all of this information. I wanted to break down, okay, so 47.2% of our patients have perio, and the remaining patient population, 94% of those people have gingivitis, but within that population, 55.7% of those people have some form of either moderate or severe gingivitis. What does that look like from a national prevalence standpoint? Now, Jerem, I'm not like you. I'm not like Curtis. I'm not a numbers person. I'm a dental hygienist. I can only count to 32. And one of my most traumatic childhood memories is sitting at the dining room table with my father as he tried to teach me trigonometry. So, of course, what did I do when I needed to figure this math problem out? I called my Midwest dad. There he is. There's Bob Sanders. Gotta love him with his little socks and his little shorts on there. And I asked my dad to help break this down for me. So here it is, according to my dad. 47.2% of our patient population across the United States have perio, which leaves the remaining 27.6% of that population as a gingivitis case, and 25.2% of our patients healthy or incipient. So this is the part where we pause. And this is the part where my dad gives me a piece of insight. And he's like, well, it's no wonder you're working so hard, Katrina. Only 1 out of 4 of your patients are actually healthy. 3/4 of your patients are diseased. They have an inflammatory condition in their mouth. So what are we doing about it? That's the next question. So I decided to take a look at what the research was out there about how we in the dental community were responding. And this is what I found out. The ADA gathers this data. They gather these claims based on the CDT codes that are submitted. And the ADA took this research study in 2016. They wanted to know how many times were patients in various age groups, 19 to 34, 35 to 49, 50 to 64. How often were these patients in these age groups treatment planned and treated with a D1110 versus any other procedural code in the hygiene chair? So again, we got to take a look at our national prevalence here, right? Patients in the 19 to 34 category, 72.3%. So 3/4 of those patients received a prophy. meaning a little over a quarter of those patients received any other procedural code, perio maintenance, scaling and root planing, full mouth debridement, for example. Now, as patients age into the 35 to 49 category, we know that their risk for perio increases. That's just the research. The AAP has told us that for years. However, what we have found is actually 87.5% of patients between the ages of 35 and 49 were treated with a prophy, meaning about 12.5% of those individuals were treated with any other procedural code. And finally, as our patients move into the 50 to 64 category, where now they're at elevated risk for comorbidities or interdependent systemic diseases that elevate their risk for perio, one would assume or hope that those are individuals that are being treated with an active periodontal therapy or at least in a periodontal maintenance program. However, what we found was a daunting 95.4% of those patients were treated with a prophy, leaving only 4.6% of those individuals being treated with really any other procedural code. So we need to take a look at the clinical spectrum of health. We need to take a look at what's out there right now, and we need to better understand what is it that we're doing to treat these patients. The second step is we need to create assessment standards. And this is a challenge, I think, in the dental profession. We need to first begin by looking at our patient's risk. When we institute things, for example, like delivering fluoride treatment to our patients, we shouldn't just be, as I say, the Oprah of fluoride. You get a fluoride, you get a fluoride, you get a fluoride, just because we want to drive our hygiene numbers up. We want to develop these treatment plans for our patients because of their risk of decay. We should be performing periodontal charting not just one time a year because that's the minimum standard, but we should be performing periodontal charting based on our patient's risk. Does our patient have active oral inflammation? Then why are we not assessing it every time? And we could say the same is true for other diseases in the oral cavity, such as sleep disorders, oral cancer, parafunctional habits, and then, of course, their subsequent connection to systemic disease. So when we take a look at assessments, for example, we know that radiographs help drive home a lot of that information for us. We know in the perio space, most of us were taught in dental hygiene and even in dental school that if you want to take a look at that bone to evaluate if the patient has bone loss, you need to take radiographs to do so. And the reason why is because the radiographs show us hard tissue. Radiographs will show us those crestal alveolar bone levels. They show us the clinical crown to root ratio. They can show us interproximal calculus or metallic restorations. And on occasion, they can demonstrate morphology of our roots, root length and root shape. However, dental radiographs have limitations. Number one, you cannot see periodontal pockets on a radiograph. You cannot see the buccal and lingual plates of bone. We cannot approximate the accuracy of shape of bony contouring or deformities. We cannot see non-calcified components of the periodontium, and we cannot see activity of the disease process. Specifically, I want to remind my colleagues out there that bone loss can only be identified radiologically when anywhere between 30 to 50% of the bone has been demineralized. Meaning, in order for you to see bone loss on an x-ray, the patient has to have already experienced 30 to 50% bone loss. So how do you identify a patient who hasn't quite gotten to that 30% bone loss mark? Well, that's where we start to integrate the importance of gathering comprehensive periodontal assessments. Again, our assessment protocol is important. We need to be providing periodontal charting, comprehensive pocket depths, bleeding points. The number one question I get is, yeah, but Katrina, if the patient doesn't have radiographic bone loss, how do I show insurance companies that the patient has attachment loss? That's notated in your recession findings. That's notated in your furcation involvements. That's notated in your mobility. You should have a robust periodontal charting. Gone are the days of just making sure that you have 5mm pockets on that perio chart. You need to make sure that your perio chart is reflective of the disease process your patient is presenting in. And it should also include verbose notation or clinical narratives, like the gingival assessments, color, contour, consistency, and texture, gingival enlargement, the patient experiencing oral malodor or pain. And then, of course, observations on the deposit that our patient is presenting with as well. I also want to notate that the American Academy of Periodontology has really turned their sights on this concept of gingival bleeding. And one of the challenges that I see is that kind of across the board, most clinicians are making a generalized observation in their clinical narrative about gingival bleeding. They're specifically stating in their clinical notes, generalized moderate bleeding, but they're not noting those bleeding points on their perio chart. And so are we actively assessing if that bleeding point is continuing to remain pervasive and persistent from appointment to appointment? Because if it is, then what we're doing is not working and we're diagnosing the wrong treatment. And the reason why the Academy is concerned about this is because they recognize that gingival bleeding is a clinical sign of interest. It typically precedes other clinical manifestations of oral inflammation. It is considered the most accurate clinical sign of inflammation. We know that when a patient bleeds, that there's an open portal. Not only can that blood vessel bleed out into the oral cavity, but it means that bacteria in the subgingival space can enter the bloodstream and circulate through the body. And currently, proceedings by the American Academy of Periodontology recommends that any site that has bleeding needs to be measured at every regularly scheduled appointment to evaluate the health or disease level. One of the things that we should be doing is continually comparing our periodontal charting, continually comparing our assessments to previous assessments. Have we seen a recurrence of disease? This could be things like either progressive clinical attachment loss, pockets that are getting deeper, pockets that are continually bleeding upon probing, pockets, of course, that are exhibiting exudate we would want to be concerned about. Are we looking and comparing the movement of our patients' radiographs over a spectrum of time? And have we seen an increase within tooth mobility? And the most important piece, and this study I found to be incredibly interesting, is the fact that patients that are periodontal maintenance patients, upwards of 2/3 of those patients exhibit one or more signs of attachment loss of at least 5 millimeters. Think about how long a typical root is. A typical root, 11, 12 millimeters. So we're seeing upwards of 50% attachment loss around that root in our typical perio maintenance patients. And subsequently, almost half present with one or more sites of active periodontal pockets. So our importance around gathering these assessments is critical. We have to be able to gather this appropriate diagnostic information in order to integrate our diagnostic guidelines. And of course, our diagnostic guidelines mean looking at the new AAP staging and grading, looking at the information that is now readily available to us to help guide our patients in excellence. And Jeremy, you and I know I could sit and talk about AAP staging and grading all day, and that's not what this particular program is about, but I encourage my esteemed colleagues, if you're taking a look at wanting to optimize and improve the ways in which you can diagnose the needed treatment, this means that we need to go directly to what our academy is telling us and integrate staging. Staging allows us to move past that one-dimensional approach that we've been using in the past when it comes to perio. So in the past, we used to use mild, moderate, or severe. And pun intended, that verbiage just wasn't inflammatory enough for our patients to understand. I think one of the challenges that have held us back as clinicians from diagnosing needed treatment in the periodontal space is the fact that this is a slow-moving, asymptomatic, progressive disease process. And our patients think if it doesn't hurt, if it's not bothering me, bleeding from my mouth is completely normal, that when all of those things are in place, it makes it very difficult for us to educate our patients on why they need an advanced procedure. And so now with our staging, we can utilize verbiage of our staging. Mr. Jones, you have stage 1 periodontal disease, or Mr. Jones, you have stage 2 periodontal disease. The good news is we caught it early. We caught it while it's in a treatable state. And this allows us to have a better conversation with our patients. One of the other things that we're looking at is utilizing the concept of grade. So grading the patient allows us to utilize a crystal ball, so to speak, to essentially evaluate what the progression of the disease process could theoretically be for this patient. It allows us to take a very patient-specific, individualized approach to identifying the ways in which we need to better control their chronic disease. So if a patient presents with what we call rapid rate onset of periodontal disease, that's a patient we need to keep on a shorter recall. And those are patients that we need to institute therapy the moment that we see that progressive disease. But more so, the thing I love about grading is it integrates the why. It tells the patient that because of these unique patient-specific risk factors, they have an elevated risk for progression of the disease process. And so our goal in diagnosing this needed treatment is to control some of those risk factors. Finally, discussing treatment needs readily with the patient. Treatment planning for our patients is ongoing. When I'm discussing treatment needs with my patient, I don't gather all my assessments and then wait until the end. I'm letting my patient know throughout the process, throughout my assessments, yikes, I'm concerned. This is what I'm seeing over here. I'm concerned. This is what I'm seeing over there. We create a co-discovery experience in my practice, meaning that when I'm performing assessments, my patient knows I'm going to be reading gum tissue numbers out loud. 1, 2, and 3 are considered stable. 4 is a warning sign. 5 and above is active infection. My patient knows to listen for those numbers. So I don't even have to tell my patient at the end of the day that they have disease. My patient has heard that by the time I've sat them up after gathering my assessments. And finally, utilizing handoffs, utilizing the opportunity to onboard other providers within the practice and other staff members in the practice, so that once we've diagnosed this treatment and we're telling the patient, this is the diagnosis of what's happening in your mouth, and these are the entities that we need to do to be able to treat this, that handoff is seamless. Jeremy, I know I just tossed a lot at everybody. As you can tell, I'm incredibly passionate about it, but my hope is that that 4-step approach helps to clarify some of the opportunities within the practice to better support their patients in excellence and better have those conversations. Again, if you have any questions, please let me know. You can find me online, www.katrinasanders.com. Shoot me an email, katrina@katrinasanders.com, or of course, find me on social media. Thank you so much. This was absolutely wonderful.
Well, I think it was phenomenal for a couple reasons. I got to just point a few things out. For those that have watched a few of these videos, you know that you're probably watching my animated face as I'm listening to these experts go through it. Because one, I know how passionate they are. I know that they love what they do, and I'm learning as well. But a couple of things that I want to point out here. One, if you guys noticed, it wasn't just that this is what you need to be doing. Katrina didn't just tell you what you probably already know. She spent very little time talking about what you already know and focused more on the process that needs to be implemented, the 4 steps, so you can get ahead of it. The thought came to me, we're constantly talking about whether it's our physical health, our mental health, and our hygiene, and our teeth. Being proactive, brush, floss, do all these things. And as I'm taking notes, I'm scribbling all over my little notepad. You can see here as I'm like, oh, I like that, right? And I absolutely love this idea of if we're telling our patients to be proactive in their hygiene and taking care of their mouth, then the process that you just walked us through is how we teach them to be proactive. Mm-hmm. I love, instead of just, hey, by the way, or through today's visit, this is what we have found. It's constant communication. You're constantly looking at it. You have guidelines, you have protocols, you have processes in place that nothing or very little is going to get through the cracks, which means you are optimizing the patient experience and their health. And I absolutely love those 4 simple steps. I want to make sure I got this right. So 1 is defining a baseline.
Yes.
Right? Mm-hmm. Creating an assessment standards. Mm-hmm. 3 is integrating your diagnostic guidelines. Mm-hmm. And the 4th is ongoing communication. Discuss it regularly. They're going to hear it through the day as they're there or through multiple visits, but the key mm-hmm. is ongoing. So it's not new or scary. They haven't heard it, but it's this ongoing thing they've heard through several visits.
Absolutely. Absolutely. That's the recipe for success in my book.
Well, we felt it and we saw it. Good. Love it. So, well, thank you, Katrina, for spending time with us today. And to our viewers, thank you once again for taking time out of your busy days to become an expert as a dental professional and really mastering that craft. We wish you the best, and we'll see you all very soon. We'll see ya.